Coming to the basic definition of hyperkalemia, hyperkalemia is defined as plasma potassium more than 5.5 millimoles. And coming to the classification of hyperkalemia, we can classify based on the severity. Mild hyperkalemia is when the potassium level is between 5.5 to 6 millimoles, and moderate hyperkalemia is when the potassium level is between 6 to 7 millimoles, and severe hyperkalemia is when the potassium level is between 7 to 8 millimoles, and very severe, which is potassium level greater than 8 millimoles. And now coming to the causes. And basically we can divide the causes into pseudo hyperkalemia, and then the renal transcellular shift causes of hyperkalemia, and then the renal causes of hyperkalemia. First, coming on to the pseudo hyperkalemia. Pseudo hyperkalemia occurs in the case of venipuncture. Actually, when we take the blood, when the patient closes the fist very tightly, sometimes there occurs a rupture of the muscle or rupture of the vessel, and there occurs a hyperkalemia. As we all know, potassium is an intracellular ion, and when some cell rupture occurs, potassium leakage occurs, and thereby causing a pseudo hyperkalemia. In case of acute anxiety, there occurs hyperventilation, and this results in acute metabolic alkalosis, and this also results in hyperkalemia. And now coming to the temperature of storage of the blood sample. This is also very, very important. The temperature of storage, which the ideal temperature should be at the room temperature. When we cool the blood, there occurs like the cellular uptake of the ions will be decreased, and thereby causing an increased potassium levels outside of the cell. And in case of warming, what occurs is there is increased cellular rupture, and thereby occurs the more leakage of potassium ions into the blood, causing pseudo hyperkalemia conditions. And in case of increased cellular elements like thrombocytosis or leukocytosis or erythrocytosis, there occurs in cellular efflux. In these cases also, hyperkalemia may occur. And there is an hereditary cause of pseudo hyperkalemia. This hereditary cause, we have a simple example like when there is a mutation of anion exchanger 1, which is the anion exchanger present in the red cell membrane. When this mutation occurs, there occurs in hemolytic anemia. When hemolysis occurs, potassium comes out of the cell, so which depicts as hyperkalemia, but this is a cause of pseudo hyperkalemia. And then next, coming to the transcellular shift. The first and the most important cause of hyperkalemia, true hyperkalemia, is acidosis. In case of non-anion gap metabolic acidosis, and in some cases of respiratory acidosis, hyperkalemia occurs. But it doesn't occur in case of ketoacidosis or lactoacidosis. And the reason being explained by this picture. We can see that in alpha intercalated cells of the collecting duct, there exists a hydrogen potassium ATPase exchanger. So in response to metabolic acidosis, our body tries to excrete more amount of hydrogen ions from your body, and for this, potassium ions are more accumulated in our body, thereby resulting in hyperkalemia. This is a very simple basic explanation for acidosis. And next, coming to the relationship between hyperkalemia and metabolic acidosis is, hyperkalemia may result in metabolic acidosis, and metabolic acidosis may in turn cause hyperkalemia. So these both are interrelated. The reason for hyperkalemia, metabolic acidosis causing hyperkalemia, we saw the basic explanation. And now coming to the reason for metabolic acidosis in hyperkalemia. In case of hyperkalemia, there is a decreased renal ammonia genesis. Usually when the H+ ions are excess in our body, it gets excreted in the form of NH4+. But here in this case, renal ammonia genesis is decreased, and thereby the ammonium ion excretion is decreased. And also there is a competition between potassium and ammonium for reabsorption by the thick ascending loop of Henle, thereby reducing the medullary gradient for ammonium excretion by the distal nephron, and thereby occurs the metabolic acidosis. And we have to remember that metabolic acidosis induced by hyperkalemia can be corrected by hyperkalemia correction itself. We need not give a separate treatment in metabolic acidosis caused by hyperkalemia. And next, coming to the other transcellular shifts, hyperosmolality. When the osmolality of the serum increases, of the plasma increases, in case of Hello, is it audible? Hello.
Continue.
In case of hyperosmolality conditions like radio contrast usage or hypertonic saline, or in case of dextrose or mannitol usage, there occurs a solvent drag effect. That means the fluid comes out of the cell into the plasma. So due to this effect, there occurs in hyperkalemia. And in usage of like in cationic amino acids like lysine and arginine, there also occurs in hyperkalemia. And this mechanism is explained by some cation potassium exchanger, which is of unknown identity and mechanism by which the hyperkalemia occurs. And drugs, coming to the drugs, beta-2 antagonist and digoxin. As we all know, the main action of digoxin is sodium potassium ATPase pump blockage, and by this, the more amount of potassium accumulates outside. There occurs in hyperkalemia. And beta-2 antagonist also inhibits the sodium potassium ATPase pump. The main action of sodium potassium ATPase pump is it transfers three sodium ion into the cell in exchange for the two sodium ion outside of the cell in exchange for two potassium ion inside the cell. So this pump is blocked, and hence the more amount of potassium is accumulated out of the cell, thereby resulting in hyperkalemia. And coming to the toxins like yellow oleander, foxglove, and bufadienolide, all these actions are similar to that of digoxin. And next, coming to fluoride poisoning, this also inhibits the sodium potassium ATPase pump, thereby resulting in hyperkalemia. And next, coming to the important depolarizing muscle relaxant, that is our succinylcholine. Succinylcholine usually doesn't result in hyperkalemia, but in case of thermal injury, or in case of neuromuscular injury, or in case of disuse atrophy or mucositis, in any case of like muscle injury, if we give succinylcholine, the succinylcholine main action is that it acts as a depolarizing muscle relaxant. So more amount of depolarization occurs. As we all know, depolarization means the sodium ions enter into the cell. But in subsequently, in case of these muscle injuries, when there is an excessive amount of depolarization, more amount of sodium enters into the cell and more amount of potassium efflux occurs, thereby resulting in hyperkalemia. So we must be very careful in these patients, and we should never be giving succinylcholine in these muscle injury patients. And next, coming to the other important transcellular mechanism is hyperkalemic periodic paralysis. And hyperkalemic periodic paralysis, there occurs an autosomal dominant mutation in SCN4A gene, which is a sodium channel gene. So when there is a mutation, occurs here, actually this hyperkalemic word is a misnomer. We may misunderstand it. Actually, during the attacks, the serum sodium potassium levels are absolutely normal. But why this hyperkalemia is, when we administer potassium, it precipitates the attacks of paralysis. So it is also precipitated by an event of rest following crisis and fasting. And the incidence is most common in the first decade, and both male and female are equally affected in this. And it most commonly affects the proximal muscle. And the most important point to remember here is it spares the bulbar muscles. In neuroconduction studies, we may see a reduced motor amplitudes, and the EMG will be silent. But after provoking the muscle with a long exercise, there may be myotonic discharges. And the treatment is mostly acetazolamide and diclofenac. And in case of myotonia, we can give mexiletine. And next, coming to the other causes of transcellular shifts are tumor necrosis. In case of any tumor necrosis or any cell lysis, usually we know it's an intracellular ion. In case of cell lysis, potassium comes out of the cell and hyperkalemia results. And in case of red cell transfusion, this is also a very important cause. In case of red cell transfusion, not in all transfusion, but in transfusion reactions, we may get hemolysis and thereby leading to hyperkalemia. And next, some rare causes of hyperkalemia is like intake of more potassium-rich foods. This potassium rich foods will be affecting mostly the older population, and those are already on the renal replacement therapy. Those CKD patients will be mostly affected if they take the potassium rich foods. It's very unlikely for our normal population to get hyperkalemia by intaking a potassium-rich foods, and these are the potassium-rich foods. And also, iatrogenic cause of hyperkalemia is when we overactively correct hypokalemia by giving IV potassium. Next, coming to the renal causes of hyperkalemia. Renal causes can be divided into actually this flowchart can be very useful in knowing the renal causes, in remembering the renal causes of hyperkalemia. Based on the GFR, low GFR, divide them based on the aldosterone levels, hypoaldosteronism or normal aldosterone. And in hypoaldosteronism, it's either an aldosterone deficiency or an we can further divide this further. First, coming to the low GFR, that in case of advanced renal polyuric patient. The reason for this being that in CKD patient, the function of the nephrons is very much reduced, and thereby the urinary flow rate is normal GFR, normal aldosterone level patients, and these occurs in the cases of congestive heart failure or cirrhosis or volume depletion, basically in volume overload status or volume depleted status. In both these conditions, there occurs a decreased sodium delivery in the distal tubule. Decreased distal sodium delivery. As we can see in this picture, that sodium is only when the sodium is transported inside the interstitial fluid, or the potassium secretion occurs. But in the case when the distal sodium delivery is decreased, this pump failure occurs, and thereby the potassium secretion also decreases, and thereby resulting in hyperkalemia. And next, before going on to hyperrenism or hyporenism, just a basic picture depicting the renin release. And macular densa cell plays a major role in helping the JG cell in secreting the renin. So obviously, when the sodium sodium secretion is high, the macular densa cell is inhibited, and the renin release is also inhibited. But when the sodium delivery is low, the macular densa cell is stimulated, and thereby resulting in renin secretion and a RAS activation occurs. As we can see, that the main things being here, the prostaglandin, which is secreted by the macular densa cell, will stimulate the renin release, and within the JG apparatus, there is a beta-1 receptor. When this beta-1 receptor is stimulated, renin release will increase. This is important to remember the causes of hyporeninemic hypoaldosteronism. Now, coming to hypoaldosteronism, we can divide that hypoaldosteronism into aldosterone deficiency or aldosterone resistance. Now, coming to aldosterone deficiency, which can be further divided into hyporeninemic and hyperreninemic. When in case of hyporenemic, diabetic nephropathy is the most important cause. In case of diabetic nephropathy, there occurs an hyperfiltration injury, and thereby resulting in hyporenism. And drugs, like as we saw in the previous picture, when the prostaglandin is inhibited, like COX-2 inhibitor or prostaglandin inhibitors, those drugs can precipitate attacks. And also beta blockers can also result in hyporeninemic hypoaldosteronism. And calcineurin inhibitors, by inhibiting the sodium potassium ATPase pump, may result in hyperkalemia. And apart from these drugs, there are also other causes of hyporeninemic hypoaldosteronism, and they are tubulointerstitial diseases like SLE, sickle cell anemia, obstructive uropathy, and HIV. And other causes of hyporeninemic hypoaldosteronism is there's a condition called pseudo-hypoaldosteronism 2. This condition is also known as hyperkalemic hypertension syndrome. This is we can just remember this as a mirror image of thiazide diuretic. The effect of thiazide diuretic, and these are just opposite. So we can remember this condition with the 5 points: hyperkalemia, hypertension, hypercalciuria, and hyperchloremic metabolic acidosis, and reduced bone density. And this occurs as a result of mutation in the WNK1 and WNK4 gene, serine threonine kinase, and also other components like KLHL3 and QLIN3, which are the components of the ubiquitin ligase complexes that regulate these kinases, and which are involved in the which regulates the thiazide sensitive sodium chloride co-transporter. So this is a very rare condition that may lead on to hyperkalemia. Next, coming on to the hyperreninemic hypoaldosteronism. As we all know, our favorite drugs, AC inhibitors, ARBs, and mineralocorticoid antagonists. When these drugs are given individually, the cause of hyperkalemia will be low. But when one or two drugs are combined, then the resulting hyperkalemia will be very high. And direct renin inhibitor, aliskiren, will cause hyperkalemia only in the combination with AC inhibitors or ARBs. Mineralocorticoid receptor antagonist majorly causes hyperkalemia via aldosterone resistance. And coming to the other causes of hyperreninemic hypoaldosteronism is primary adrenal insufficiency. When the adrenal is itself gone, then the aldosterone levels will be very low, and thereby resulting in hyperkalemia. And the causes of primary adrenal insufficiency are autoimmune disorders like polyglandular endocrinopathy and Addison's disease. And it may also include infections like HIV, cytomegalovirus, TB, and disseminated fungal infection. The important point to note is HIV can also cause primary adrenal insufficiency, and it can also damage the macula densa cells. The previous one we saw, the macula densa cells can also be affected by HIV. And next, coming on to the infiltrative causes, amyloidosis and malignancy can also result in adrenal insufficiency. And drugs like heparin and ketoconazole. The mechanism of action of heparin is that it blocks the angiotensin 2 receptor in the zona glomerulosa, thereby resulting in decreased aldosterone secretion, and thereby hyperrenism also occurs. And ketoconazole, by inhibiting the steroid synthesis, it causes adrenal insufficiency. And hereditary causes. Hereditary causes includes congenital hypoplasia of the adrenals, or it can be congenital lipoid adrenal hypoplasia or aldosterone synthase deficiency. And it may also occur in case of adrenal hemorrhage or infarct. And coming to the next one, aldosterone resistance. Aldosterone resistance occurs also actually tubulointerstitial disease all causes severe form of aldosterone resistance in severe conditions like SLE, sickle cell anemia, amyloidosis, and obstructive uropathy, and post-acute tubular necrosis. And pseudo-hypoaldosteronism 1. We saw that time pseudo-hypoaldosteronism type 2, that is hyperkalemia, hypertension syndrome. Here we are seeing pseudo-hypoaldosteronism type 1. It can be either an autosomal recessive or an autosomal dominant disorder. Autosomal dominant disorder occurs due to loss of function mutation of mineralocorticoid receptor. It usually improves in adulthood. But autosomal recessive condition, it causes lifelong salt wasting, and there occurs in lifelong hypotension and hyperkalemia. And other drugs which can cause aldosterone resistance are ENaC blockers, as already said, mineralocorticoid receptor antagonist and calcineurin inhibitor. And these are the drugs which inhibit the, that impair the renal potassium excretion, starting from aldosterone synthesis, heparin and ketoconazole, and decreased aldosterone release. Decreased aldosterone releases with the AC inhibitors and ARBs. And next, coming on to decreased renin release with the NSAIDs and beta blockers. And again, coming on to mineralocorticoid receptor antagonists like spironolactone and eplerenone. And decreased ENaC channel function. ENaC channel blockers like amiloride and triamtrin, and trimethoprim and pentamidine also blocks the ENaC channels. And next, coming to decreased sodium potassium ATPase pump in the renal system, and this is mainly caused by our calcium urine inhibitors. And other mineralocorticoid receptor antagonist is some Yasmin 28. It's a contraceptive that contains progestin, which inhibits the mineralocorticoid receptor. And now coming on to the clinical presentation of hyperkalemia. We have discussed the causes. We have discussed the every causes, like low GFR in case of CKD and normal GFR. We have seen the normal aldosteronism with the decreased distal sodium delivery. In hypoaldosteronism, we have seen aldosterone deficiency and the hyperanemic causes and hyperanemic causes. And finally, we have seen the aldosterone resistance. Next, coming on to the clinical presentation. The main and foremost presentation in case of hyperkalemia, it's the cardiac manifestation. The one thing which should come to our mind thinking about hyperkalemia is the arrhythmias it causes. So hyperkalemia means cardiac manifestation should come onto our mind automatically. So just brushing up the basics about the action potential in our cardiac muscles. And as we all know, in phase 4 of action potential, we have the open potassium channel, which maintains the resting membrane potential as at minus 90 millivolt. And as the phase 0 occurs, there is a rapid depolarization by the rapid influx of sodium influx. And in phase 2, there's a transient potassium channel opening, resulting in potassium efflux. And in phase 2, there is an influx of calcium, which counterbalances the potassium efflux. And in phase 3, there is a calcium channel closes, but the delayed rectifier potassium channel is open, and there occurs the resting membrane potential drops back to minus 90 millivolt. And the most common change during our ECG findings will occur with the T waves. The reason for it being the potassium being the major ion during repolarization. So when there is a hyperkalemia, the ECF to ICF gradient, it decreases, and thereby the resting membrane potential becomes less negative, and thereby the height and velocity of phase 0 of action potential is decreased. So there occurs a slow conduction velocity, and this is the reason for absent P waves or slowing of P waves and QRS prolongation. The reason for peaking of T waves occurs because of the rapid phase 3 or steeper downslope. Here we can see the slow downslope because of the slow opening of the potassium channel. But in case of hyperkalemia, there will be occurring a steeper downslope. And there is also occurrence of shortening of the phase 2 because this results in shorter QR interval. And these are some ECGs. In case of mild hyperkalemia, we can see the peaking of T waves. You can see the peaking of tall T waves, and the characteristic feature of the T waves in hyperkalemia is they are tented, meaning they have a narrow base and a pointed tip. And QT interval also begins to shorten in case of mild hyperkalemia. In case of moderate hyperkalemia, we can also see that the T waves are taller. The T waves are taller and they become more tented here. More tented, and the QRS complex begins to prolong. And the QRS complex begins to prolong, and also QT interval is very well shortened here. And next, coming to in case of severe hyperkalemia. In severe hyperkalemia, there occurs a PR prolongation also starts to occur, and there is a widening of the QRS, and this S wave starts to merge with the T wave, and this pattern is called a sine wave pattern. And the most common lead changes which we see are in the precordial leads because they are more close to the myocardium, and the changes are very easily seen. And sometimes in case of severe hyperkalemia, there occurs an ST elevation. This may resemble an acute ST elevation MI. So we can differentiate them by the presence of wide QRS, and we can differentiate by the presence of wide QRS, and the QRS axis will be abnormal in case of hyperkalemia. The most as we see the progression, we can see the absent P waves. The P waves are not visible here. So this is also this also occurs in case of severe hyperkalemia. Why? Because of this absent PGFR, there is a slowing of sinus impulse across atria, or sinus impulse will be traveling to a specialized intraneural pathway. So there may be an absent P waves. And there occurs in further ECGs, we can clearly see the sine wave pattern, white QRS and S merging with T, and sine wave pattern occurs. And here also the sine wave QRS is very widely prolonged, and then merging with the T waves can be very well seen here. And here the this ECG usually precedes a ventricular fibrillation or an asystole. So here the rhythm is very unusual. And this is a VF. Usually we see only a polymorphic VT or VF in case of hyperkalemia, and never only we see a monomorphic VT or VF in case of hyperkalemia, and never a polymorphic VT or VF in hyperkalemia. This is a point to be noted. And this is a simple explanation, diagrammatic explanation. And coming to the neurological manifestation, as we all know, in case of hyperkalemia, the resting membrane potential will be raised, but the excitability of the cells will be increased, but the strength of contraction of the cells will be decreased, thereby resulting in an ascending paralysis. So ascending paralysis is most common in the case of hypokalemia, but also hyperkalemia can also result in an ascending type of paralysis. It will mostly involve a diaphragm and respiratory failure. This is an important point to differentiate from a hyperkalemic periodic paralysis. In case of hyperkalemic periodic paralysis, bulbar vessel involvement is very rare. So we can differentiate from that. And now coming to the approach to hyperkalemia. When a patient comes with hyperkalemia, first we have to see whether the potassium level is very high or ECG changes are present. If either one of them is present, then we have to start emergency therapy. Before going on to the causes, we have to emergency intervene them, and then we have to come to the causes. If the cause is obviously a pseudo hyperkalemia, no further action is required. There is no pseudo hyperkalemia, if the ECG changes or if the hyperkalemia is not very severe, then we can come to the next history and physical examination and basic laboratory test. And the laboratory test includes serum potassium, serum sodium, serum magnesium and calcium, along with serum osmolality. And also in urine, we have to do the same urine sodium, potassium and urine osmolality. And this osmolality is used in calculation of TTKG, which is very useful in arriving at the diagnosis for cause for hyperkalemia. And next, coming to the other points, after these investigation, if there is an evidence of increased potassium load, like excess intake or such causes can be treated accordingly. And if there is an evidence of transcellular shift, as we have seen the causes of transcellular shift like metabolic acidosis, or in case of beta blockers or digoxin toxicity or hypertonicity, can be treated accordingly. And next, coming to the urinary potassium excretion. When the urinary potassium excretion is decreased, that is less than 40 millimoles per day, we have to look at the urine electrolytes. The urine sodium is decreased, then the cause is obvious. The distal tubular sodium delivery is decreased, and hence thereby causing a hyperkalemia. And if this is normal, then we can come to the TTKG. The TTKG is more than 8. TTKG is nothing but the the element, like the cortical collecting duct has an inherent element to secrete potassium. So that is TTKG. When this is present, there is a reduced tubular flow. Reduced tubular flow, as we discussed earlier, occurs in case of advanced renal failure. And if the TTKG is less than 5, that means there is a reduced distal potassium secretion. The potassium secretion is inherently deficient. For that, what we do is we give an external aldosterone, that is a fludrocortisone is given. If upon giving fludrocortisone, the TTKG is increased, then we can easily say that the aldosterone levels are low. So as we have already seen that in hypoaldosteronism, we should next look upon the renin levels. Can be hyperrenism or hyporenism, and we have already discussed the causes of hyperenemic hypoaldosteronism and hyporenemic hypoaldosteronism. So it is easy to diagnose. If upon giving fluorocortisons, if still the TTKG is low, then we can think about aldosterone resistance. And aldosterone resistance, as we have already discussed, these are the causes of aldosterone resistance. So finally, concluding about the hyperkalemia approach, we have to emerge the first and foremost thing which we have to do is give an emergency therapy before evaluating hyperkalemia. And after correcting the ECG changes or after the patient becomes stable, then we can further evaluate the causes, pseudo hyperkalemia or transcellular shift or renal causes. Renal causes we have seen that in a normal normal GFR with a decreased sodium delivery or decreased GFR, and then coming to the TTKG less than 5, then we are coming to the hypoaldosteronism and we can treat accordingly. And this is the TTKG, urine potassium by urine sodium upon urine osmolality by serum osmolality. And these are the set of investigations we usually do in a case of hyperkalemia. Urine pH is important in case of hyperkalemia because in case of hyporenemic hypoaldosteronism, there occurs an usually there occurs a decreased ammonium excretion. As we have already seen earlier, there occurs a decrease in ammonium excretion, thereby causing a positive urine anion gap, and urine pH is always less than 5.5. And we term it as the renal tubular acidosis type 4 in case of hyperkalemia associated one. And now coming on to the management. Now management basis, we can classify them as those having the effect on serum potassium and those not having the serum effect on serum potassium. Calcium gluconate we are giving only as a membrane stabilizer and not to decrease it has no effect on the serum potassium. And those which are having the capacity to decrease the serum potassium. And in decreasing the serum potassium itself, we can classify them in the treatment into two. Those which causes the those which correct the transcellular shift, thereby they are not affecting the total body potassium. They'll never affect the total body potassium. They'll only cause the extracellular to intracellular shift of potassium. And those that causes the reduced total body potassium. So those that causing the transcellular shift are insulin, beta-2 agonist, and sodium bicarbonate, which we use very rarely. And those that decrease the total body potassium are GI eliminators, diuretics, and renal replacement, at last the renal replacement therapy. Now coming to the management of hyperkalemia. In management of hyperkalemia, first what we have is calcium gluconate. Calcium gluconate, usually give it is available in the person 10% calcium gluconate, 10 ml over 2 to 3 minutes we should give. And the onset of action is very rapid, between 2 to 3 minutes. And duration of action is about 30 to 60 minutes. And it can be repeated multiple times, provided it should not cause hypercalcemia. If we suspect a case of hypercalcemia, then it can be given in 100 ml of 5% dextrose over 20 to 30 minutes. And next, coming to the insulin. Insulin, by causing the transcellular shift, it can result in, it can be used in the treatment of hyperkalemia. The insulin which we use in our hospital is R10 and D25. According to Harrison, it can be given in D50. So the onset of action is within 10 to 20 minutes and the peak occurs in 30 to 60 minutes. And the duration of action, it extends over 4 to 6 hours. And in case of hyperglycemia, we can give insulin without D25. And in case of coming to the other immediate responders for immediate treatment, these three are the immediate treatment in hyperkalemia. Inhaled beta-2 agonist. Inhaled beta-2 agonist, what is preferred is albuterol, which is available in the 10 to 20 mg quantity. It should be mixed in 4 ml of NS and it should be inhaled over 10 minutes. And the onset of action is within 30 minutes and the peak occurs in 90 minutes and the duration of action is approximately 2 to 6 hours. And next, coming on to beta-2 agonists are actually end-stage renal disease patients. Approximately 20% of them are resistant to the effect of beta-2 agonists. So it should not be the only treatment in them, and we have to give the insulin and also calcium gluconate in them. And IV soda bicarbonate, it's very rarely used, and usually it's 150 milliequivalents is given in 1 liters of dextrose 5 water, and the onset of action is intermediate. It acts in 4 to 6 hours. And our long-acting one is our sodium SPS, that is sodium polystyrene, which is given in the concentration of 15 to 30 grams in 33% of sorbitol. It has a very long duration of action. Like its onset is late. Like it takes about 24 hours to act, and the duration of action is very low for them. You have to repeat the doses every 4 to 6 hours. And coming to the calcium gluconate, as we all know, with the hyperkalemia, the resting membrane potential is increased. And the calcium gluconate, what it does is that it increases the threshold potential. It does not affect the resting membrane potential. It increases the resting threshold potential, thereby preventing the excitability. And next, coming to the last management in hyperkalemia, and this sodium polystyrene sulfonate, as we have already seen, takes a very long time to act. Usually we give it in the concentration of 15 to 30 gram with 33% of sorbitol. This is an unabsorbable resin, and the mechanism of action for this is the sodium is exchanged for potassium in our body, and potassium is excreted in the feces. And the most important complication for this SPS is intestinal necrosis. And next, coming on to the other one is patriomer. Patriomer is a non-absorbable polymer, and it binds potassium in exchange for calcium. It not only binds calcium, it also binds magnesium and sodium. So the main complication of patriomer is it may result in hypomagnesemia. And next, coming on to ZS, that is zirconium sulfate. It is also an inorganic non-absorbable crystalline compound which exchanges sodium and H plus for potassium and ammonium. And what are the other measures of treatment? As we have already seen that in case of decreased distal sodium delivery, like in case of either in case of volume overload state or in volume depleted state. In case of volume depleted state, we can give IVNS. So that that can be the treatment option in case of volume depleted state. In hypervolemic state, we can treat using loop and thiazide diuretics, which in turn increases distal sodium delivery. And the final management for potassium hyperkalemia, the main and the best management for hyperkalemia is renal replacement therapy. And in that also, HD is more valuable than PD. And the amount of potassium that is removed in HD depends upon the relative distribution of potassium between ECF and ICF, and also on the type and surface area of the dialyzer used, and also on the dialysis duration and dialysate and blood flow rate, and it depends on so many factors. So at last, renal replacement therapy is the best and permanent measure for hyperkalemia. Thank you.
That was a very good presentation, ma. Hello.
Thank you, sir.
ஓகேவா. ஸோ பேசிக்கலி எல்லாமே சொல்லிட்டேன் நீ. அது வந்து அது இப்போ என்ன ஒரு ஹைப்பர் கலீமியா அப்படின்னா ஒரு பேஷண்ட்டுக்கு என்னென்ன பண்ண போறீங்க?
ஃபர்ஸ்ட் எடுத்தோடனே ட்ரீட்மெண்ட் ஆரம்பிச்சிரணும் சார்.
சரி, கரெக்ட்.
அப்புறமா தான் காஸ் கண்டுபிடிக்கணும்.
என்னென்ன பண்ண போற?
ஃபர்ஸ்ட் IV calcium gluconate 10 ml 10% calcium gluconate over 10 minutes மாதிரி கொடுத்துருவோம் சார். அடுத்து வந்துட்டு பேஷண்ட் ஹைப்பர்கிளைசீமியால இல்லைன்னா 25Dல R10 போட்டு கொடுத்துருவோம் சார் ஓவர் 10 to 20 minutes. நெக்ஸ்ட் வந்துட்டு லைக் நம்ம ஹாஸ்பிட்டல்ல இருக்கிறது வந்து சால்பியூட்டமால் நெப், அது ஒரு 4th ஹார்லியா வைக்க சொல்லலாம் சார். ஸோ இது வந்து இது வந்துட்டு லைக் இத பண்ணிட்டு ஒரு சைக்கிள் பண்ணிட்டு திருப்பி இசிஜி எடுத்து பார்க்கலாம் சார். அது இன்னும் சேஞ்சஸ்
ஓகே
இருக்குன்னா திருப்பி இன்னொரு டைம் குடுக்கலாம் சார்.
ஓகே. இப்போ சால்புட்டமால் எவ்வளவு கொடுக்கணும், எப்படி கொடுக்கணும்? சால்புட்டமால் நீங்க எவ்வளவு வழக்கமா கொடுக்குறீங்க?
மினிமம் half an hour கொடுக்கணும்.
எவ்வளோ?
மினிமம் half an hour கொடுக்கணும்.
நீங்க கொடுக்குற டோஸ் எவ்வளவு? நீங்க நெப்புக்கு வைக்கிற டோஸ் என்ன? நெப்புக்கு எவ்வளவு டோஸ் வைக்கிறீங்க? பீடியாட்ரிக்ஸ் எல்லாம் வச்சிருக்கீங்களா?
1 ml salbutamol, 4 ml NS sir.
ரஃப்லி வந்து ஒரு 2.6 2.9 மில்லிகிராம் தான் வைப்பீங்க. கனகவல்லி நீ எவ்வளவு டோஸ் சொன்ன?
சார் 10 to 20 mg 10 to 20 mg in 4 ml என்ன சார்?
எவ்வளவு வித்தியாசம் இருக்கு? அப்ப நம்ம தப்பா கரெக்ட் பண்றோமா அதை கரெக்டா கொடுக்குறோமா? சொல்லு, தப்பா கொடுக்குறோமா கரெக்டா கொடுக்குறோமா?
நீங்க சொன்னது அல்புட்டிரால் தானேமா?
ஆமா சார்.
சரி, ரெண்டு ஒண்ணுதான்டா.
ரெண்டுமே ஒண்ணுதானே சார்? சால்புட்டமால்
ரெண்டு ஒண்ணுதான், ரெண்டு ஒண்ணுதான். ஹலோ
சார்.
அதான் இப்போ இப்போ நம்ம கொடுக்கறத இப்ப கரெக்டா தப்பா? ஹலோ கனகவல்லி,
சார்.
ஆக்சுவலி அதுதான் என்ன சொல்லுவாங்கன்னா எவ்வளவு 10 to 20 mg கொடுக்கணும். சரியா? நம்ம கொடுக்குற 430 எல்லாம் பத்தாது. ஃபர்ஸ்ட் 10 to 20 mg கொடுத்துருக்கோம் பேஷண்ட்டுக்கு, அதுதான் மேக்ஸிமம் டோஸ் அப்படின்னு எப்படி சொல்லலாம் சொல்லுங்க? சொல்லுங்க, எப்படி நம்ம தெரிஞ்சுக்கலாம்? ட்ரெமர், பேஷண்ட்டுக்கு ட்ரெமர் வர வரைக்கும் கொடுக்கணுமா? நெஃப்ரோலா தான் சொல்லுவாங்க. சரியா? சோ ட்ரெமர் வர வரைக்கும் கொடுக்கணும்.
ஓகே சார்.
ஓகேவா? அதுதான் ஐடியல் இது. ஓகேவா? சோ பேஷண்ட்டுக்கு ட்ரெமர் வர வரைக்கும் நீங்க கொடுக்கணும். அந்த அளவுக்கு அதுதான் எஃபெக்டிவ், அதுதான் சால்புட்டமாலோட எஃபெக்டிவ் இது. சரியா? சோ இப்ப அடுத்து வேற என்ன சொல்ல வரணும்னா, கால்சியம் பொட்டாசியம் ரிமூவ் பண்ணுமா?
இல்ல சார்.
பொட்டாசியம் ரிமூவ் பண்ணாது. என்ன பண்ணும்?
கார்டியக் மெம்பரேன் ஸ்டெபிலைசேஷனுக்காக கொடுக்குறோம் சார்.
அவ்வளவுதான். ரைட். சரியா? சோ அவ்வளவுதான், நம்ம கால்சியம் குளுக்கோனேட் அதுக்கு தான் கொடுக்குறோம். சோ அடுத்து வேற என்ன பண்ணும்? இன்சிடென்ட் டிரான்ஸ்செல்லுலர் ஷிஃப்ட், பைகார்பேட் டிரான்ஸ்செல்லுலர் ஷிஃப்ட், சால்புட்டமால் டிரான்ஸ்செல்லுலர் ஷிஃப்ட். சரியா? அடுத்து லூப் டயரிட்டிக்ஸ் நல்லா வேலை செஞ்சால் பொட்டாசியம் பைண்டிங் ரிசைன்ஸ் இருக்குல்ல, பாலிஸ்டிரீன் சல்ஃபனேட், கேலக்சேட், பேட்டிரோமர், அது ஓகேவா? இது வந்து பொட்டாசியம் பைண்டிங் ரிசைன் வேலை என்ன தெரியுமா?
தெரியல சார்.
பேஷண்ட் கிட்ட ஏதாவது வாங்க சொல்லியிருப்பீங்களா? நிறைய பேஷண்ட்ஸ் கிட்ட, சிகேடி பேஷண்ட்ஸ் கிட்ட ஒரு 15 கிராம் சாஷெட் 150 rupees கிட்ட வரும். ஒரு 15 கிராம் சாஷெட் பேஷண்ட்டுக்கு அது நீ டிடிஎஸ்க்கு மேல டிடிஎஸ் கிட்ட கொடுக்குற மாதிரி வரும். சரியா? ஸோ இதெல்லாம் அதெல்லாம் கொஞ்சம் காஸ்ட்லி, பார்த்துக்கோங்க. ஸோ இது ஏன் நான் சொல்ல வரேன்னா, ஏன் இப்போ ஒரு தடவை ஹைப்பர்கலீமியால இருந்தாலுமே இட் இஸ் நாட் நெசசரிலி பேஷண்டோட பொட்டாசியம் லெவல் 8 இருக்கு சார், இசிஜில சேஞ்சஸ் இல்லை சார்னா நீங்க அதுக்காக நீ வந்து ஹைப்பர்கலீமியா பொறுமையா கரெக்ட் பண்ணணுன்ற அவசியமே கிடையாது. All it takes is one VT or VF to kill that patient, and that VT or VF can occur anytime. Doesn't irrespective of the ECG changes, can occur anytime. So all I want you to do is put that PD first. That's all I want you to do. சரியா? பேஷண்ட் அது நீங்களே 2-3 தடவை இந்நேரம் பிடி எப்படி போடுறதாவது ஒரு பிடியாவது போட கத்துக்கோங்க நெஃப்ரோபேஜி கூட சேர்ந்து. சரியா? ஒரு ஆத்திர அவசரத்துக்கு ஒரு எங்கேஜ் சிகேடி எல்லாம் வரானா ஒரு பீடியை மட்டும் போட்டு விட்டேன்னு வச்சுக்கோ, அதுக்கப்புறம் அவனுக்கு ட்ரீட்மெண்ட்டே வேண்டாம். அதுக்கப்புறம் பொறுமையா அவனை அடுத்த நாள் 2 நாள் கழிச்சு கூட பண்ணிக்கலாம். All I want you to do is keep the potassium in the normal range. That is what I want you to do. If you do that, the patient has been saved from imminent threat of death. The patient has been saved. Okay வா? ஸோ நான் அதுதான் சொல்லணும்னு நினைச்சேன். ஸோ எப்படியாவது அடிச்சு பிடிச்சி கஷ்டப்பட்டு நைட்டுக்குள்ள பிடி போட்டுருங்க போஸ்ட் அட்மிஷன் மேல. நவீத் சார்.
ஹலோ. ஒரே ஒரு கொஸ்டின், இது which diuretic is more அது எனக்கு ப்ரிஃபர்ட், அதாவது இப்போ ஹைப்பர்கலீமியாக்கு நீங்க டயரிட்டிக் கொடுக்க போறீங்க அப்படின்னா தயசைடா லூப்பா?
லூப் டயரிட்டிக் சார்.
இதுதான் எல்லாருமே ஆன்சர் பண்றீங்க. ஆக்சுவலா அது வந்து தயசைட் டயரிட்டிக்.
ஓகே சார்.
ஓகேவா, என்ன ரீசன்னு பார்த்து எனக்கு நெக்ஸ்ட் இதில் சொல்றீங்களா?
ஓகே சார்.
அப்புறமா இது அந்த சூடோ ஹைப்போ அல்டோஸ்டிரோனிசம் டைப் 2 சொன்னீங்கல்ல?
ஆமா சார்.
அதுக்கு ஏதாவது பேர் இருக்கா?
டைப் 2க்கு தான் ஹைப்பர்கலீமியா ஹைப்பர்டென்ஷன் சிண்ட்ரோம் சார்.
அதுதான், அதுக்கு வேற ஏதாவது பேர் இருக்கா? கார்டான் அதானம்மா?
சார்
நான் தப்பா சொல்றேனா? கார்டான், GORDON கார்டான் சிண்ட்ரோம்.
எஸ் சார்.
அதுதானே அது? இல்லை நான் தப்பா சொல்றேனா? ஹைப்பர்கலிமிக் ஹைப்பர்டென்ஷன் வித் ஹைப்பர்குளோரிமிக் மெட்டபாலிக் அசிடோசிஸ் வித் ஹைப்பர்கால்சியூரியா, இன்னொன்று என்ன சொன்னீங்க?
லைக் டிக்ரீஸ் லைக் போன் மினரல் டென்சிட்டி டிக்ரீஸ்டா இருக்குன்னு சொல்லிருந்தேன்
கரெக்ட்
சார்.
தான்.
அதுவும்
அது ஜீன் மியூட்டேஷன்ல தான் வரும். அதுதான் WNK ல தான் வரும்.
அது வந்து கார்டான் அதுக்கு பேரு.
எஸ் சார், கார்டான் தான் சார்.
ஏன்னா நிறைய பேருக்கு கார்டான் சொன்னா தெரியும், அப்படி சொன்னா தெரியாது. சூடோ ஹைப்போ அல்டோஸ்டிரோனிசம் டைப் 2 இல்ல, ஏன்னா டைப் 1க்கு அப்படி எதுவும் பேர் இல்ல.
இல்ல சார்.
ஓகேமா, வேற எதுவும் இல்லை. அதுக்கப்புறம் என்னன்னா இன்னும் முக்கியமான பாயிண்ட் என்ன, சிகேடி பேஷண்ட்ஸ் வில் பெட்டர் டாலரேட் ஹைப்பர்கலீமியா. இப்போ 2 பேஷண்ட் இருக்காங்க, 2 பேத்துக்குமே ஹைப்பர்கலீமியா இருக்கு. இப்போ யாருக்கு ஃபர்ஸ்ட் கரெக்ஷன் கொடுக்கலாம் அப்படின்னு நீங்க நினைக்கும் போது, இப்போ ஒருவேளை சிகேடி பேஷண்ட்டுக்கு 6க்கு மேல இருக்கா, 6க்கு மேல இருந்துச்சுன்னா அவனும் இஸ் ஈக்குவல். ஆனா அந்த சிகேடி பேஷண்ட் 5.5 to 6 இருக்கு, இன்னொரு பேஷண்ட்டுக்கு வந்து 5.5 இருக்குன்னா ஃபர்ஸ்ட் ட்ரீட் தட் பேஷண்ட். ஏன்னா சிகேடி பேஷண்ட்ஸ் கேன் டாலரேட் ஹைப்பர்கலீமியா.
ஓகே சார்.
ஆனா நார்மல் பேஷண்ட்ஸ்க்கு வந்துச்சுன்னா they won't tolerate.
வேற யாரோ ஒருத்தன் ஏகேல இருக்கானா அவனுக்கு ஃபர்ஸ்ட் போடுங்க, அதுக்கப்புறம் அவனுக்கு வந்து போடலாம். ஓகேவா?
ஓகே சார்.
சரி, anyone else? வேற ஏதாவது டவுட் ஏதாவது இருக்கா? That's all. Thank you, ma.
Thank you, sir.